This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery, published in 2026. It's titled Frequency and Timing of Programmable Shunt Valve Adjustments After Aneurysmal Subarachnoid Hemorrhage.
This is a topic that hits home for anyone who spends time in the neuro ICU or the outpatient clinic. We know that hydrocephalus requiring ventriculoperitoneal shunt, or VPS, placement is a very common sequela in patients who have suffered an aneurysmal subarachnoid hemorrhage, or aSAH.
Exactly, Dr. Aris. And while the technology has advanced, the management remains a challenge. The paper highlights that programmable shunt valves have really changed the game because they allow for the non-invasive correction of both overdrainage and underdrainage. In theory, this should significantly reduce the need for surgical revisions, which is a huge win for patient safety and healthcare costs.
Right, but the how and when are still a bit of a black box. As the authors point out, even though we use these valves daily, the actual data describing the frequency and timing of postoperative valve adjustments, specifically in the aSAH population, remain limited. That's what this study sought to characterize.
It's an important distinction. The CSF dynamics in an aSAH patient are very different from, say, a normal pressure hydrocephalus patient or a pediatric case. We're dealing with the aftermath of hemorrhage, blood products, high protein levels, and often fluctuating intracranial pressures during the acute and subacute phases.
Let's dive into the core of the study. The researchers focused on three main variables: the incidence of adjustments, the direction of those setting changes, and the temporal pattern, meaning when exactly are these changes happening after the VPS is placed.
Starting with the incidence, the study provides a clearer picture of how often we are actually reaching for that programming tool. In this aSAH cohort, they found that a significant portion of patients required at least one adjustment. It's not a set it and forget it situation.
And that brings us to the direction of the settings. When we talk about programmable valves, we're essentially balancing on a tightrope between underdrainage, where the patient's ventricles remain enlarged and they might have persistent symptoms, and overdrainage, which carries the risk of subdural hygromas or even hematomas. Ilara, what did the paper note about the direction of these shifts?
The study tracked whether the valves were being turned up to higher pressures to mitigate overdrainage, or down to lower pressures to address underdrainage. By characterizing the direction, the authors could see which complication was more prevalent in the post-aSAH population. It turns out, managing that balance is a dynamic process that often requires multiple course corrections as the patient moves from the ICU to the step-down unit and eventually to rehab.
The temporal pattern is perhaps the most clinically relevant part for our residents and fellows listening. If you know when a patient is most likely to need an adjustment, you can tailor your follow-up and imaging more effectively.
Precisely. The paper sought to map out that temporal pattern following VPS placement. If we see a high frequency of adjustments in the first few weeks, it suggests that the initial setting chosen at the time of surgery might need more scrutiny, or that the early inflammatory phase of aSAH recovery drastically alters CSF resorption.
It's also about avoiding that surgical revision the authors mentioned. Every time we can fix a drainage issue in the clinic with a programmer, rather than taking the patient back to the OR for a valve change, we're reducing the risk of infection and the physiological stress on a brain that has already been through the trauma of an aneurysm rupture.
And for our practicing neurosurgeons, this data helps manage expectations. If the data shows a high frequency of adjustments, we shouldn't view a postoperative adjustment as a failure of the initial surgery, but rather as a standard part of the physiological optimization of that specific patient.
Well put. This study fills a significant gap in our literature. By understanding the incidence and timing of these adjustments, we move closer to a more standardized protocol for post-aSAH shunt management.
It really emphasizes that the programmable valve is a dynamic tool. The study's focus on the temporal pattern reminds us that the patient we see in the ICU on day 5 might have very different drainage requirements by day 30 or day 90.
A great deep dive into a very practical paper. For our listeners, keep an eye on these temporal patterns in your own practice. Are you adjusting more for underdrainage in the early phase, or are you bumping pressures up later to avoid late-onset hygromas? The data in World Neurosurgery gives us a much-needed benchmark.
That's all the time we have for today. We hope this look at programmable shunt valve adjustments in the aSAH population was helpful for your clinical practice.
Thank you for joining us on the Neurosurgery Hub podcast. We'll see you next time.